So let me start by introducing myself. My name is Leo Caraballo. I'm the Early Career Psychologist Trustee for ABAP. I'm board certified in clinical psychology, and this is part of a webinar series led by the ABAP Psychologist in Public Service Task Force in collaboration with the Early Career Psychology Task Force. So we're very happy today to have a presentation on rehabilitation psychology. So I'll turn it over there. Thank you.
Hi there. I'm making sure that I'm not muted. Okay, so I'm Dr. Tackett. I'm on the board of Rehabilitation Psychology, and I'm going to do a quick run through of this talk. And I'm hoping to make a case for boarding generally and boarding specifically in rehabilitation. Partly it's my home, and I would say that it's a good fit for VA psychologists for a variety of reasons, but I'll talk with you some about our values and our process. So this is me. I'm at the Seattle VA Hospital in spinal cord injury care, and been in this position for 20 years, and before that, other VA positions throughout this VA and also in Denver. Okay, so why do this? Well, I'm going to go quickly through these slides, but I would say that there are benefits to board certification that you're probably aware of, but the reality is that these are in the works, and board certification across different professions has been becoming more important. You think about physicians are about 95% board certified. You're going to have a rare physician who's not in some specialty, and many in several specialties. Other professions are building board certification into their process, and so I think that as psychology moves forward as a healthcare profession, board certification is going to become a more typical thing. So it is in rehabilitation, it's a pretty widely expected step in your career. So unfortunately, only under 5% of psychologists in practice are board certified, and I think that's partly because of our culture, but also it's just not really baked into the training sequence as of yet. So we're still getting there, and I would say, all these personal things aside, this is how professions build in another level of protection for the public when it comes to specialty populations. So I'll get to that in a little bit, but so why rehabilitation? Well, rehabilitation programs a lot of times see board certification as a minimum standard. Some Hopkins, for example, requires board certification for hospital privileges, and CARF accredited programs are increasingly aware that this is a good standard of care for an expectation for psychologists in their programs. Also, I would say my process, I came through a non-rehabilitation training background. So into my career, I started the process of seeking board certification, and it really helped me clarify who I was, what my values were, sort of the fetch of the sort of background of our profession and how we make decisions in clinical circumstances. So I really did clarify my identity through this process, and there's really no, training, supervision, reading, all those things are great, but the board certification process in our case with our board is a very developmental process. And so you really do get a chance to have a curated experience of understanding why we do what we do in our field. Quite a developmental experience for me personally, and I hear that over and over. I don't really, that people say, I'm happy to have the letters and everything, but this made me way better at what I do and way more clear about why I do what I do, and it gives me tools for communicating those reasons to all kinds of stakeholders. And so it makes you a more compelling writer in terms of like how you help change programs and whatnot. So what is rehabilitation? It's really the application of psychological knowledge to individuals with disabilities. And we think of disabilities in a very broad net. So sometimes people say, well, I work with chronic pain, that's a disability. I work with psychiatric illness, that's a disability. Brain injury, that's a disability. So thinking about how psychology principles and the knowledge base that encompasses our field can be applied to improving the livelihood of a person with any kind of disability, because it includes the social environment that they live in and the barriers that our culture places for people with any kind of notable difference. So that's one of the big pieces that that represents our values, is advocating for removing barriers to participation. And I'll identify some other things that make rehabilitation unique, but I would encourage you that like most of what people do in the VA fits well with rehabilitation as a specific specialty. So what do we try to do? We try to increase function. We try to reduce the impact of disability, activity limitations, and restrictions to social participation. And those, confronting those barriers is a critical piece of this work. We work with families, we work with teams, we consult with other professionals, and everything we do is seen in a social context. So those social psychology ideas that come out of Lewin and the sort of the movement of social psychology through the 50s and 60s really informs our work. And what is this whole idea of a team approach is now really popular in healthcare, and I think that rehabilitation's been doing team care for 60 or 70 years, and so we really do have a handle on what helps teams work better, and how a psychologist like interfaces with a team in a very integrated way. So I feel like we are at the, we're ahead of the wave here in many ways in terms of how healthcare is evolving. I'm not going to, I'm going to go over requirements, but it's really pretty clearly spelled out, and it's common across all the boards. So, these are the general things that you need. And please feel free to contact me or anyone at ABPP with specific questions, because I certainly didn't fit the mold of like, a rehab training background and a rehab fellowship and like rehab supervisors. It's really so there are many ways to figure this out, and don't just say, oh, I don't have this and so I can't do that. It's really much, please reach out to us, and we can try to make a thing work. So, the process is you submit your general credentials, pay the fee, and then you start the process. Everybody needs 2 years of supervised practice. As you can see, like fellowship and internship so internship doesn't count, but fellowship does. Supervisors can be ABPP, they can be physicians. It doesn't really matter. It needs to be someone who's a rehab person though. So 3 years of experience, 2 of which must be supervised. So that's, sometimes there's a 2-year fellowship, and then 1 year out of 2-year fellowship will do it. I had lots and lots of years of experience, but very little supervision. And so it was really hard for me to put this all together, but eventually did it. For endorsements, just get people to write. There's a form that they fill out. It's not like, it doesn't need to be an onerous, like, 5-page letter saying that you walk on water. It's really like a form. It's not too bad. So early entry option, I really encourage people to do this. It saves money and it also just gets you started, and you can start recording credentials that kind of as they accrue, and you don't need to declare a specific specialty. So this is a nice way to get started early. So how do you do it? So you apply, there's a review by the central office, then our board looks at it, then you do your practice sample and do oral exam. Most people are most intimidated by the oral exam, so I'm going to spend a little time on that. It's actually not the hard part of the process. The oral exam is really the fun part, and I'll tell you why. The practice sample is a big deal. It takes a long time. It's a lot of work, but this is where the real growth occurs. I'll tell you, in writing, this is a 50-page document, and you have to cover a lot of territory in that 50 pages. So you become very disciplined about it. You become very targeted and strategic, but really it helps you kind of clarify why you do what you do. And this is using clinical practice guidelines, research that you're aware of, training experiences that you've had, your decision trees, like I thought about this, but instead I did that. And it's really clarifies, it's a crystallizes your thinking about how we do how we make decisions in our care. So these are two clinical cases. You are allowed to use other things like research projects and whatnot, but I think it's just ridiculously hard to do it that way. So I always encourage people to just pick two cases and write about the two cases, because this is a clinical credential and not a research credential or other things. So just think that the cases are the way to go. Yeah, so breadth. We really want to have you really want to have cases that are a little bit different. And so as I said, it's 50 pages, APA format. You can't shrink it down and do like 9-point font, so you get like extra words and everything. The point is that like this is a discipline of getting your work down. And so I always tell people, say what you did, say why you did it, cite some reason for your decision, and then move on. Don't go over and over and over. Adjustment to disability is one of our big competencies. How did you measure it? How did you treat it? And people love to write about it because that's the whole reason for us doing what we're doing. But you could spend half a page on it and you're done. You don't have to keep going over it. The nothing annoys practice sample reviewers more than an unreadable practice sample, so please make sure it's in good shape. So we like people to tell what they do and where they do it, talk about the cases and how they ended up in their caseload, and then start hitting those competencies as you go. And they're spelled out in our manual in a behavioral fashion. So like, if you do this, then you will have demonstrated that competency. And so it's a contract. We're asking you to do this. If you can say I've done it, then you will have satisfied that. You'll have satisfied that competency, and we could move on. And so the process as a whole, with the practice sample and the oral exam, you have to demonstrate all of these 30 something competencies. And so we want most of them done in the practice sample, and then we'll have a few left in the oral exam. And that makes the oral exam process fairly straightforward. We're aiming for these specific competencies that weren't met in the practice sample. Diversity, consumer protection, your own personal impact on the case. There's very specific things that your mentor, each person is assigned a mentor on the board, and that person walks you through the process. So you could say, am I on the right track here? How does this look? What am I missing here? And so we all mentor people through the writing process, and it is a very close relationship that has to do with succeeding and getting you through it. And of course, we like to know how the case turns out, although it doesn't have to be a successful case. It can be any case that you think is rich in this regard. So we, you can look at the competencies on the website. They're spelled out very specifically, but they focus on, every board has the same general structure. I think that the unique ones for rehab have to do with advocacy and consumer protection. That constitutes one of these things where having a social psychology perspective on disability drives us towards this issue of advocacy and consumer protection. We want to know about your assessment and evaluation of general psychology things, but also very specific things to disability like sexuality, substance abuse, pain, vocational access. And these I'll let you look at on the website. I feel like we've come a long way to specifically define our expectations. And we have supplemental competencies in these 4 areas, and these are things that aren't required for board certification. But if you do them, then you can also include them in your work, and there are behavioral definitions of what we would expect you to be able to do to be competent in these areas too. So it's a simple method of demonstrating your competency in your supervision practices or your teaching practices or whatnot. Every case needs to have a supporting document. Usually it's a part of a case note or a snippet of a testing report or whatnot. But the point is for us to be able to see that it's an actual person that you treated. So the oral exam, 2 minutes left. So the oral exam is half a day long, costs a bunch of money. You can do it either on a video, like a virtual oral exam now, which is quite cool, or you can go to our annual meeting, which is in February, and do it in person. The examiners are very collegial. They encourage a lot of back and forth. It's you meet with one examiner at a time. So you meet with and there's actually 3 examiners who run your exam, but you meet with them one at a time, and their job is to get you to succeed at meeting these competencies. So they will query you, they will encourage you to the right direction, they will ask you questions. Our job as examiners is to give you the chance to demonstrate this competency. If you can, great. If you can't, that's a problem, but we won't trick you. We really want to say, this is what we need you to show us, and we're transparent about that. We set a very high bar in the practice sample. Like, we really want them to be solid and like have a lot of content. And that way, when you get to the oral exam, you're ready to just have a collegial conversation about your cases, about new cases. It tends to be a very non-confrontational process, no matter how anxious you are, which of course we all are, but the process tends to be very collegial. So you have 2 vignettes that you cover, and you present basically like a case presentation on a mythical vignette. Then you have an ethics exam where you are presented with cases, like very brief ethics situations, and you're supposed to hone in on what the issues are. And then the third thing is questions about your practice sample. So like, going back to this case that you presented, I noticed that you had a lot of interventions related to vocational rehabilitation. Let's talk some about that. So it's basically going back to your clarifying things in your case. So you get there and you sign a form that says you won't tattle on like what the exam is. It's a 4-hour thing that's very anxiety provoking, but not too bad. We're trying to help you get through the process. You can look at these slides later, but I'm out of time. So we do clinical vignettes. We do the ethics exam. It's usually 3 or 4 cases. And you're not supposed to solve the cases. You're supposed to explain what you notice, what the big ethics issues are. And then here's some resources for you to look at. And also, of course, current literature is the very best thing. So I am gonna leave it at that. And we got 10 minutes, 9 minutes, I guess, for questions. So you can ask me questions about your specific situation, or you can put things in the chat, or we can play charades or something if you want.
Is it okay if I jump in and ask a question?
Please do.
So I'm in a side specialty clinic, and so I do substance use treatment work, and that's what my fellowship is in.
Yeah.
So and you mentioned that there's kind of a broad area with this. So would that apply or not?
Well, it depends. I mean, so this is a common question, and the question I would ask has to do with I'm assuming that if your patients are anything like mine, there's lots of comorbidities. So you have people with brain injuries, you have people with amputations, you have people with all kinds of physical problems. And so whether or not substance use disorders are a disability or not doesn't really matter. I mean, if you can argue that you have a approach that's informed by social psychology, and that you're in a team setting, then, and you use consultation, then I think you could make it work. I know that the substance use folks are working on their own board, and this is like in the works, but it's God knows how long this will take. It could, sometimes it happens fairly quickly, but other times it takes a long time. We had a recipe going to have like a subspecialty in across several boards. So it would be like rehabilitation with a subspecialty in substance use, and then clinical with a subspecialty in substance use. But I think that was abandoned because and it's been my contention all along that substance use has its own freestanding literature and intervention tradition that could be its own specialty. So I would say, so another piece of this is that you could always sit for one specialty, and then when substance use comes along with their own board in 2 to 5 or 10 years or whatever, you could sit for that as well. But just to say that you could make this work, and feel free to reach out to me at any time. I'm in the VA address system with any guidance or questions on it, because I would be very happy. We've made this work for lots of different people, and then other people have said, oh, maybe clinical is more appropriate, or maybe health psychology is more appropriate. But I would say, I mean, if you have patients with physical disabilities, then that's an easy yes.
Thank you.
Hi, Dr. Tackett. Thank you for the presentation. I was wondering about the recommendation letters. Would those need to be from board certified rehabilitation psychologists? I don't remember what you said about that.
No, they could be anybody. As a matter of fact, not anybody. I guess I shouldn't say that. They need to be from people who are in the rehabilitation field. So they could be psychologists. I'll take my example is easy to describe. I had my supervisor in my position was a physiatrist, like a PM&R doctor, and he wrote a letter. And then I had a kind of an administrative supervisor who was a trauma therapist, a psychologist, and so not a board certified person, but still a licensed psychologist. And he wrote a letter. And then I had a letter from a couple of other psychologists who I work with. And so not necessarily like your traditional, like here's a rehab person with a rehab fellowship, and then here's rehab chops to show. But it really was like, I'm putting together these endorsements of people who know my work and like are familiar with it. So they have to be rehab people, but not necessarily psychologists, and certainly not board certified people, partly because there's not that many of us, and there's only a couple hundred of us out there. So like, who gets supervised by numerous licensed people except in those very special programs?
Yeah.
Thanks for the question.
Thank you. So I'm at the Atlanta VA, as you know, and I actually just went to a talk today by one of the interns because they have a health psychology track. And so there's like a health psychology journal club. And so I try to infiltrate these things, right? Because there's so much overlap with rehab, but there's not a lot of knowledge in certain communities, like about what rehab is, what we can do. So I would like to eventually have a training, rotation, or maybe a postdoc at some point. So I guess a rotation on an internship, and then eventually down the road do a postdoc. But board certification isn't necessary for that, correct?
It's not necessary, but
it's recommended as the first step.
It certainly would help you along the way. I mean, I think that like one of the things about this process is that it creates like this network of colleagues who are kind of, in the same, have the same goals, and would help you pursue these, these aspirations. I think that one of the cool things is that the competencies that we've defined are they are the same for training programs. They are the same for our identity as a specialty. And so like we as you're building a training program, your experience of boarding would certainly make a difference. I think it would make it seamless.
Thank you. Where is everyone else at? I'm just curious. I don't know if you've already done introductions or if we're like out of time, but I would love to know. I'm in
Seattle.
I know you're in Seattle.
I'm in Houston at the Houston VA.
Oh my gosh, do you know Emily Kellogg?
Yeah.
So I was on internship with her at Memphis. She's like one of my best friends. So she was just talking about coming to visit me yesterday. Anyways, that's so cool.
Small world.
Yes.
And Leo's at Walter Reed in Washington.
Oh,
yes.
Gotcha. Exciting.
And I'm in Boston.
Nice.
Okay, well, if you have any other questions, just shoot me an email. I'm happy to get with any of you about it, and good luck with your process. It's, it takes time, but it's really it's a good process, and it'll help our field, help the field of psychology advance in the healthcare professions universe. So please think about it.
Thank you.
Thank you for presenting.
You bet. Bye-bye.
Bye-bye.